Dr. Dent yesterday. Unfortunately, she is not here today, and probably she will join us later, but I'm not sure about. We have a case of a 62 years old lady with non-small cell lung cancer, metastatic disease, who had treatment with numerous different chemotherapies and currently was on immunotherapy with nivolumab. And she presented with acute myocarditis. Actually, it was a very interesting case. So patient was admitted to ICU, and she was from plane. So first of all, a few words about her cancer history. She was diagnosed in 2012, and at that time she had chemoradiation treatment. Then in August 2013, she was diagnosed with brain metastatic disease and started with another type of chemo, and she was fine for few months, and then again new progression, and we started with nivolumab for disease progression. During this treatment she had once pericardial infusion, which was drained in 2014. So since October 2015 she was on nivolumab. She interrupted this treatment 3 times for non-cancer occasions, but she still continues with this treatment. So she presented in ICU with next history. She developed 3 episodes of mild diarrhea along with worsening dyspnea. She was on a flight from Europe where she was on holidays to Toronto, and her flight was diverted to Ottawa for an emergency landing as her condition deteriorated in flight. So 1 or 2 days prior to admission she had 1 episode of diarrhea and unusual cough that was different and wet from her chronic one, and she was transferred from airport directly to our ICU, and at ICU she was intubated and required multiple vasopressors and inotropes for her profound cardiogenic shock. Her ACGs have shown diffuse CT elevations. Her initial echo unfortunately was not very good quality, but it still showed 30 or 40% of left ventricular ejection fraction with regional wall motion abnormalities, notably in apex. She had treatment with solomidrol for possible myocarditis with viral etiology, but main concerns were about autoimmune disease related to nivolumab. Clinically, she was improved very rapidly and was extubated 48 hours after, and the cessation of vasopressors and inotropes. She had done well, and she had high dose of steroids and usual heart failure management. So her echo on day number 4 showed significant improvement, and the patient was transferred to a community hospital in Toronto. So the main questions to audience is, can nivolumab, which is new treatment, lead to a delayed scenario of myocarditis with profound shock? Second question is, should we use MRI, and when we should do this procedure? If you think about autoimmune myocarditis, should the patient have endomyocardial biopsy? So if you sure believe that nivolumab can cause this, what should we do with this treatment, and how long should we give steroids for her? So this is main questions. We discussed with Dr. Dent yesterday, and actually a few words about nivolumab. Now we have a number of new medications in lung cancer treatment, and especially only in 2015 we have 5 new drugs, and 2 of them immunotherapy medications, which is absolutely new. We have very few trials about these medications. First of them was pembrolizumab and nivolumab. And nivolumab actually on ASCO 2015 was the most popular drug, and it was the main hot topic of ASCO last year. And another 3 medication, which is target treatment. So we have a number of new therapies, and still a lot of toxicities unknown. If we will talk about nivolumab mechanism of action, it's immune therapy and immune modulation therapy. We know that a number of cancer cells can produce special proteins that prevent immune system from detection and killing these cells, and one of them is PD-L1 and PD-1 receptor. So nivolumab is a first checkpoint inhibitor which blocks this protein PD-L1 and allows the immune system to kill this cancer cell. So it's a new type of immune therapy, and one trial was published about this medication in comparison with classic chemotherapy with docetaxel, and we can see a number of side effects from nivolumab, but there is no any concerns about cardiac toxicity. The main side effects was fatigue, nausea, sometimes decreased appetite, but nothing about myocarditis or cardiomyopathy. And also, if we will look at information for the patients, there are a number of serious side effects, but nothing about possible cardiac toxicity. We have long discussion with our cardiac oncology clinic about this, and after numerous consults, we have these 4 statements from our cardiologist. If it is possible, I want to hear comments from you also. First of all, in case of we suspect myocarditis, we should do cardiac MRI as soon as possible, to at least to confirm presence of myocarditis, but not about etiology. Endomyocardial biopsy is a good method, but it should be done only in experienced center and give us additional information. Nivolumab associated myocarditis probably should be treated with high dose of steroids, because main etiology component is related to T cells mediated effect. And should be treated like acute rejection. And statement number 4 was that nivolumab associated myocarditis, if we suspect this, we should stop nivolumab treatment, and there is no way to re-challenge this treatment again for now, because we don't have any information about second effects of this treatment. So this is our main statement, and may I ask you again about this question and hear your comments about this one. So what do you think about immune therapy and autoimmune myocarditis? How often can we see this complication, and what do you think, could it be possible to have autoimmune myocarditis so acute and with very good recovery in few days?
So Olexiy, great presentation. It's Joe Carver. So I have one question and then I have a couple comments. When did this person present? What's the time frame?
So
when was she in the hospital? In what month?
Once again, sorry.
Yeah, because it seems like she started nivolumab
in
like
November.
October, yes, November.
2015, so it's almost 6 months, and she presented in hospital in June, end of June.
Okay, so this is, I mean, it's kind of amazing because right before I called in, I was reviewing stuff for next week, and next Tuesday I'm seeing an 86-year-old physician who has metastatic melanoma and on pembrolizumab has developed heart failure, not to this profound degree, but heart failure, and it's actually the first person with a checkpoint inhibitor that I've seen with full-blown heart failure. But it's clearly there are scattered case reports when people have been biopsied. There's been like a lymphocytic infiltration, and people do respond to steroids. I've seen a whole bunch of people who present with shortness of breath and fluid retention with not much change in LV function that is this overall inflammatory reaction that responds to steroids, and they get better pretty quickly. And then at least here, people have been re-challenged with lower doses, and but it's certainly possible, and I think maybe as a group we ought to be biopsying, at least getting MRIs and biopsying these people to try to understand better what actually is happening. The people that I've seen up to the person who's coming on Tuesday have all had reactions within the first month or 6 weeks of taking medication and not 6 months out. The person I'm seeing next week has been on it for just about the same amount of time, November of 2015, 11 cycles, and developed symptoms of heart failure. So it's clearly, it's been reported with all of the checkpoint inhibitors. So IPI, nivolumab, and
pembrolizumab.
And pembrolizumab.
Yeah.
Yeah. Okay, this is great. This is like fantastic that you presented this today.
Sure, it's absolutely new treatment for us. We just started this new sub-specialty of oncology, like immune oncology, and it become more and more popular because of these new drugs. And I can tell you that nivolumab now is almost gold standard for metastatic non-small cell lung cancer, and this drug testing for many other malignancy sites. So I think it will be very popular in a few years, and probably we have to think about additional guidelines for cardiac toxicity for these checkpoint inhibitors. If it could be, it's very serious side effect. It was not detected during first clinical trials, but probably we need more experience to understand why it happens and what should we do in medical oncology setting for this.
Olexiy, could you show us that EKG with the diffuse ST segment elevation?
I'm sorry, but I have only this slide. I don't have actual ACGs, so I cannot show it now, but I can ask our cardiologist to send it to me, and I will be able to share in group later.
Olexiy, because of the initial echo, do we need to rule out coronary artery disease or coronary vasculitis as part of this, which we could take a look with coronary CTA to get a quick look at the coronaries.
Yeah, so Eric, kind of interesting, there's an article in JACC, I think this week or last week, about the number of people who present with heart failure where the coronary artery disease is the most common cause of heart failure, and the percentage of people who are actually investigated for ischemia upon presentation is abhorrently low. I mean, it's shocking. So this person should clearly have an evaluation for coronary disease. Also, I agree.
Olexiy, is that something that you have access to, a coronary CTA, to take a quick look and look at the walls for vasculitis as well?
I don't have access now because I don't have MRN of this patient. I can tell you that we discussed this story with Dr. Dent yesterday, and she gave me this short review of case. So I can provide you this information later, but today I don't have access to actual history chart.
I think the MRI is a great idea, and we'll give you some really nice pictures, and you can see if you have any scar tissue. You can also, if you have MOLY, you can do a T1 MOLY and look and see if there's any diffuse fibrosis, as well as lead gadolinium enhancement to look for any scar tissue. And of course, the lead gadolinium enhancement will also show the myocarditis, and changes of edema can be picked up on T2 weighted. And so there's lots of opportunities with a good number of sequences on MRI to be able to hone in on the questions that you're asking. And if you have MRI with navigation package, you can look at the coronaries, and on some people you can see the coronaries quite well, and so that might also be helpful with the coronary artery disease if your group has any experience with looking at coronary arteries with breath navigation. I don't think we have a lot of clinical experience with this drug. There, certainly one of my students, Luke, was just doing a quick search and found several cases reported with nivolumab, basically where there was myocarditis, which responded quite nicely to steroids. And so I don't think we have a good picture, and we need to do an analysis of all the case reports, bring them together, obviously report this as post-marketing data for the FDA so that they can gather this data as well and put it in their post-marketing update of the drug information. Sebastian, do you have any comments?
Yes, thank you. Congratulations for Olexiy for the great presentation. I have one comment because my wife is oncologist. She's working in the Department of Lung Cancer Diseases, and she has observed the atypical myocardial infiltration and inflammation in myocardium during nivolumab or other drugs associated with PD-1. And this reaction was observed in computer tomography imaging. So I think that magnetic resonance is the better method for this reaction, for evaluation of this reaction. And I think MRI could be helpful. And I think that steroids may be useful for treatment, because when we observe inflammation, myocarditis, and pneumonitis, on other inflammations associated with immunotherapy, steroids is very effective. And I think that in this specific situation, steroids may lead to better outcome. So I think that the future in oncology associated with lung cancer is for immunotherapy, and we will observe the many patients with the similar reactions, and I think that we could observe the many interesting cases.
What do you think about endomyocardial biopsy? How difficult to perform this method in center, and could it be a routine procedure for all patients with these symptoms? So it's still very sophisticated, and only individual concerns about this.
Yes, good question. We usually use MRI in such patients, and of course MRI can lead to the specific diagnosis, and we can differentiate between inflammation, myocarditis, and between the patients with other types of abnormalities. I think about ischemia reaction, and I think that MRI is the best method for this differential diagnosis. And usually we use steroids for these patients, especially we have observed some patients with pneumonia associated with immunotherapy and with concomitant myocarditis, and steroids was very effective, were very effective. And I think that MRI is good method, better than computed tomography. We use usually in daily practice, and we refer such patients for biopsy very rare, because this is very invasive procedure, and MRI can give us the final diagnosis without myocardial biopsy. But I know that cardiologists, invasive cardiologists like myocardial biopsy, but I think that MRI is enough for our differential diagnosis.
It's Zaza. Can you hear me?
Yes.
Hello, it's Zaza from Tel Aviv, Israel. I want to discuss the question on the myocardial biopsy. I think that putting biopsy in the situation that MRI is better than biopsy, I think it's a, let me say, even dangerous position, because if the patient has some kind of virus, myocarditis, viral myocarditis, that is even contraindication for steroid treatment, blind steroid treatment. Only situation when steroids are helpful are giant cell myocarditis. So I think good practice is, especially in the patient with such hemodynamic compromise, with cardiogenic shock. I think you need very prompt diagnosis, and biopsy can provide you prompt diagnosis. You cannot do MRI in cardiogenic shock patient. So actually you treat it in blindly. It was very good outcome, and I say only that it was a well done work, but on the other hand, it's dangerous to treat patient blindly with steroids when you have the possibility to do cardiomyocardial biopsy. When it is not available, yes, you have no other answer. You have to give steroids and hope to the best. But when you have this issue, I think you have to do this. It appears in every guidelines that patient with acute decompensating heart failure without any other reason, when it is acute onset, you have to do endomyocardial biopsy to know with what problem you are dealing with. And MRI is not a substitute. MRI could help you to predict the outcome of the patient, to do some prognostication, but I think endomyocardial biopsy in this case was absolutely justified. Thank you.
Well, it's certainly easy to do the endomyocardial biopsy, external jugular vein, and get some information very quickly, and so that's not much of an issue in terms of doing it and performing it in low risk.
Yes, it's a low-risk procedure in good hands.
Another question about autoimmune myocarditis. How often you usually see this pathology and this disease in your practice, and do you know any cases of recurrent disease? So I mean, one dose and try to do it, because if she has lymph node positive and she's young, she will progress. She has the risk of progression without this treatment around 60% in next 3 years. So I think she will have beneficial, much more beneficial results with trastuzumab treatment. At least we can try with careful cardiac monitoring. It's cardiology. It's oncology perspective, but.
I think it's a good perspective, because I think that the main issue for this patient is cancer, and I think we can manage a heart failure if it develops, and maximum will stop the drug if it will cause some kind of deterioration. Thank you.
You're welcome. Thank you so much for the possibility to do this presentation, and thank you so much for these valuable comments. I think that this idea with website and new drugs monitoring is very important, and I will do all I can do to help you with this project. So thank you so much.
We have a comment from Daryl Abernethy that says, be certain all of these cases are reported to the FDA and to Health Canada. This is critical for such a new class of drugs. So, of course, please note that. Couldn't communicate by mic because Abernethy site is self-muted, but this was the message. Okay.
Okay.
So thank you so much. John Fay will be in touch with you in terms of working on the registry of new drugs and new drug complications, Olexiy. And so we can build something into our website that'll be a blog as well as a registration of medications, and people can sort of respond as things happen in the field. So I appreciate your great presentation. Give my best to Susan, and look forward to hearing from you next month.
Thank you. See you. Bye.
Bye, everybody. Bye, Joe. Bye, Sebastian.
Hi, thank you.